Hello everyone, I'm Shara Bang. Today we're going to talk about pregnancy-induced hypertension, also known as PIH. The hypertensive disorders during pregnancy are conditions where a woman has high blood pressure that starts during pregnancy. The exact cause is still unknown, but in preeclampsia, it's linked to problems in the blood vessels and poor blood flow. So this conditions is more likely in first-time moms, teenagers under 20, women over 35, and those carrying twins or more. It also happens more often in a woman with diabetes, low income, or other pregnancy complications like HMOL or too much amniotic fluid.
So as for the assessment, the symptoms usually develop during the third trimester, except in cases of gestational trophoblastic disease or the HMOL. So the client is at risk for seizures and other complications up to 48 hours after the delivery. Next is the types of pregnancy-induced hypertension or the PIH. So we have three. First is the preeclampsia, second is the eclampsia, and third is the severe eclampsia. So ano ba yung mga signs and symptoms or yung mga nakikita natin sa tatlong yon? So first is the preeclampsia. So sa preeclampsia, yung signs and symptoms dito is elevated ang BP, of course. So yung BP nila is 140/90, and then meron din silang proteinuria. Positive 1 and positive 2. And then, meron din silang edema. And then, sa eclampsia naman is same lang sa signs and symptoms ng preeclampsia. Pero, ang pinagkaiba nila, ang BP ng eclampsia is 160/100. And then, ang proteinuria nila is positive 3. And then, meron din silang edema. Pero worse kapag nagkaroon ng severe eclampsia. Kapag nagkakaroon na ng seizures. So, ano ba yung mga signs and symptoms or mga nakikita kapag may seizures na si patient? So, pag nagsumasakit na yung ulo ni patient or headache, and then kapag may visual disturbance or blurring of vision na si patient or nanlalabo na yung paningin nila. So, third is may epigastric pain na si patient. So, ano ba yung pwede nating ibigay na gamot kapag nagkakaroon na ng seizure? Ano ba yung makakapag-prevent ng seizure? So, nagbibigay po tayo ng magnesium sulfate. And ano nga ba yung antidote ng magnesium sulfate? So, yung antidote ng magnesium sulfate is calcium gluconate. So, ano yung nursing intervention na ginagawa natin kapag nagbibigay tayo ng calcium gluconate? So, first is we need to monitor the renal function. Next is the calcium gluconate should be on the bedside. And third, we need to inform the physician if the RR or the respiratory rate is below 10 CPM or 10 cycles per minute.
Next, we have the three nursing diagnoses to consider. First, we have deficient fluid volume related to fluid shifts and vasospasm. Second, anxiety related to the condition and potential complications. And third, we have risk for injury related to seizures and elevated blood pressure.
I'm gonna discuss implementation and collaborative care. The only cure for PIH is delivery. The goal of care is to deliver a healthy, viable infant while safeguarding the mother's health. First, bed rest at home is indicated if preeclampsia is mild. Why do we have to bed rest? Because resting reduces maternal activity and stress, which can help lower systemic blood pressure. Hospitalization, if severe, until fetus is mature enough to be delivered. Bed rest on left side to facilitate uteroplacental perfusion. So, if preeclampsia is severe, hospitalization is needed for close monitoring and timely delivery if maternal or fetal risk increase. A quiet, calm environment is maintained to decrease CNS stimulation. So a quiet environment can lower the risk of eclampsia. Side rails should be up and padded for clients with severe preeclampsia who are at risk of progressing to seizure. So, padded side rails help prevent injury from uncontrolled movement if seizure occurs. Raised side rails also prevent the client from falling out of bed during altered consciousness or convulsion. Third, a high-protein diet without salt restriction is indicated. Restricting salt intake may result in hypovolemia and fetal distress. Diuretics should not be used for the same reason. Fourth, implement frequent assessment every 15 minutes to 1 to 4 hours as indicated by client condition. These include BP, pulse, respiration, edema, deep tendon reflexes, and clonus cheeks. Assess client for headache, visual disturbance, and epigastric pain. First, why do we have to monitor the BP, pulse, and respiration? Because elevated BP is the primary sign of worsening disease. Then pulse and respiration help assess cardiovascular and respiratory function, especially if medications like magnesium sulfate are used. So we have also deep tendon reflex, and clonus are signs of CNS irritability. Headaches, visual disturbances, and epigastric pain. These are red flags indicating severe preeclampsia or risk of seizure. Fifth one, polycatheter is inserted to monitor renal function. Then, strict intake and output. So, we have to track fluid balance closely because fluid overload can lead to pulmonary edema, and dehydration may worsen uteroplacental perfusion. We have also to evaluate urine for protein because protein in the urine is one of the diagnostic criteria for preeclampsia. Then assess daily weight because if we detect sudden weight gain, this may indicate fluid retention, edema, or else worsening hypertension. The sixth one, we have to monitor fetal well-being by continuous electronic fetal monitoring, so we can identify if the fetus is late deceleration, reduced variability, or bradycardia, which suggests fetal distress, and serial non-stress tests and biophysical profile and or amniocentesis as indicated.
Number 7, the administration of magnesium sulfate and monitoring for toxicity. One of the key pharmacologic interventions in pregnancy-induced hypertension is particularly in severe cases or those progressing to preeclampsia or eclampsia, is the administration of magnesium sulfate. It is used to prevent seizures, which is a life-threatening complication of eclampsia. When we administer this medication, we need to close monitoring. The therapeutic level of serum magnesium is between 5 to 8 mg per dl. Levels beyond this can lead to magnesium toxicity, which is a medical emergency. The signs of magnesium toxicity includes the decreased urine output, which less than 30 ml per hour, which can cause magnesium to accumulate in the body because it is excreted through the kidneys. And loss of deep tendon reflexes, and also respiratory depression, which respirations falling below 12 to 14 per minute, and flushing, hypotension, and even cardiac arrest in severe cases. As nurse, it is critical to monitor vital signs, DTRs, and urine output hourly, and always have a calcium gluconate readily available at the bedside, as it is the antidote to magnesium toxicity and can be administered in the case of emergency. Next is the preparation for cesarean birth. In case where the maternal condition deteriorates or when the fetus has reached the maturity, the team may decide to proceed with the cesarean delivery. This decision involves the obstetrician to assess the fetal development and maternal stability, the anesthesiologist, especially when dealing with magnesium sulfate, which can potentiate muscle relaxants. Nurses who prepare the client both physically and emotionally and assist with the pre-op and post-op care. Timely delivery is often the definitive treatment for pregnancy-induced hypertension and its complication. Next, number 9 is the client and family teaching and support. Another important aspect is educating and supporting both the client and her family. Many clients with mild preeclampsia may not feel sick despite having elevated blood pressure and proteinuria. This can make it difficult for them to understand the importance of interventions such as strict bed rest, monitoring symptoms, medications, compliance. As nurses, we must provide clear explanation of the risks and benefits. This includes the offer emotional support, encourage family involvement in care, clarify any doubts or fears about hospitalization or potential complications. Next is to monitor the newborn for depression. Why? Because magnesium sulfate crosses the placenta and it may affect the newborn. Therefore, it is important for us to monitor the neonate for signs of respiratory or neuromuscular depression after delivery. A collaborative care with the neonatal team is necessary to perform thorough assessments, initiate resuscitation if needed, and provide continued monitoring in the NICU if symptoms persist. Lastly, a continue monitoring postpartum for pregnancy-induced hypertension complications. It is important for us to remember that seizures can still occur up to 48 hours postpartum. As nurses, our responsibility is to continue monitoring the blood pressure and watch for signs of worsening conditions. Example, for severe headache and visual disturbances. And also to maintain magnesium sulfate therapy as prescribed and provide seizure precautions and support during the critical recovery period. In conclusion, managing pregnancy-induced hypertension requires a comprehensive and collaborative approach. Nursing responsibilities includes medication administration, patient education, fetal and maternal monitoring, and emotional support. Collaboration with obstetricians, neonatologists, and the entire healthcare team ensures the best outcome for both the mother and the child. By staying vigilant and informed, we can help them to prevent complications and promote a healthy pregnancy and delivery.
And for the evaluation, the client does not experience eclampsia or the HELP syndrome or the hemolysis, elevated liver enzymes, and platelet count. And the client delivers a healthy, mature infant without further complications.